You are listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, editor of the Journal of Dermatological Treatment and professor of dermatology at the Wake Forest University School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for healthcare professionals.
Hello, I'm Dr. Steve Feldman. Welcome to Medscape's In Discussion series on psoriasis. Welcome to this very special episode where we're joined by the dynamic duo behind the best place to get dermatological information, Dermasphere. Oh, it's so good. It's so efficient. It's so entertaining. Our guests are Dr. Luke Johnson and Dr. Michelle Tarbox. Dr. Johnson is an associate professor of dermatology at the University of Utah, and Dr. Tarbox is a professor of dermatology at Texas Tech University Health Science Center. Together, they've built Dermasphere into a go-to resource for dermatology professionals, blending clinical insights with evidence-based discussion. Today, we're flipping the script, interviewing them about what's new in dermatology, focusing on psoriasis in 2025 and their predictions for the future of the field. Welcome to In Discussion.
Super excited to be here.
Thank you so much for having us.
Michelle, Luke, how did you two get together?
I was lucky enough to get to train Luke. So I came to Texas Tech University in beautiful sunny Lubbock, Texas in 2013. I moved there because my parents lived in Lubbock and had some health needs, and they really needed a dermatologist in the program at Texas Tech. And sometimes God just tells you what to do. You know, I needed to get home to my parents. I needed to be closer to my mom and dad. And I got to have the great honor of helping to take care of my mama as she dealt with, unfortunately, Alzheimer's, which she passed from in December. But I got to have 11 wonderful years getting to be by her side and help her with that. And as that part of that process, I jumped into the residency program at Texas Tech. Now, I did not get to be part of selecting Dr. Luke Johnson for residency, but I like to think he would have been one of my first choices for his residency class because he was an absolutely fantastic resident.
I don't know about being a fantastic resident, but the rest of it checks out.
Now, how did you get started in podcasting?
When I joined the faculty at the University of Utah, there was a group of faculty that were doing innovative things with technology and with ideas, and I thought that looks like a cool thing to be a part of, so I asked if I could be a part of it, and they said, sure, it might help if you have a particular project or idea that you want to explore while you're part of us. And I said, well, when I was a resident, I wanted there to be a dermatology podcast out there with updates from the literature, so I wouldn't have to try to read them. I could just listen to what somebody else thought was worth listening to while I was exercising or driving or whatever. And back then, there were not a lot of options. There are a lot more dermatology podcasts now, but I said, what if I make that? And they said, that sounds good. And then I immediately thought of Michelle Tarbox as the ideal co-host, and to my continued surprise, she said yes, despite everything else that she has going on in her life. And we've been rolling along for the last 5 years or so.
Did you start with a physician-focused program, or was there a patient program at the same time?
We started with the podcast by dermatologists for dermatologists and for the dermatologically curious. And then about a year or two into it, some of the folks at the University of Utah asked if we wanted to make a podcast intended for patients as well. And so we said, sure, we know how to make podcasts. That sounds fun. And so we had a podcast called Skincast for a time. And then it ended up being a heavier lift than I thought it would be. We kind of picked all the low-hanging fruit and talked about acne and warts and molluscum and eczema and stuff. And then we were like, okay, well, what else is there? And we already had a lot of time devoted to Dermasphere, and it's kind of a labor of love. And I decided I didn't have time for another of those labors. And so Skincast went by the wayside. The podcast episodes are still out there, I think, and I think we had some good discussions on them. Currently, we're focused on our podcast for other healthcare providers.
I get to travel a lot, speak to a lot of dermatologists, and everywhere I go, they invariably tell me, I heard you on Dermasphere.
Aww.
Do you have any sense of how big Dermasphere is?
Yeah, there are metrics to pay attention to that. So, an average episode these days gets about 3,000 listens over the course
Wow.
of its quote lifetime, which is small compared to something like, Freakonomics or the NPR podcasts, but is big when you think about how many people are listening to you in an average talk that you give to other dermatologists. So I think that's pretty good. And then we've been listened to in like 110 countries and so on. You can track all this stuff, and it's kind of fun to look at.
Does your promotion committee at your university appreciate the impact that you're having?
I'm very fortunate at Texas Tech. They heavily value education and they heavily value sort of devotion to improving access. And there has been appreciation from my institution about both the teaching impact as well as improving the access to dermatologic expertise and information through the podcast, because our listenership is largely dermatologists, dermatology residents. We have a lot of allied health professionals that listen, and dermatologically interested medical students, as well as some of our partners in industry. And we have the ability to kind of disseminate important information, like potentially important drug interactions to be aware of. Sometimes these are things that the interaction checkers for major EHRs don't catch. Getting that information out into the listenership could potentially help prevent like a fatal side effect. I think that can be really significant, but it's also fun. We can build community, we can learn together. We got actually approached at one of the AAD meetings we were speaking at together in the Resident Jeopardy session by a group of military dermatologists. And they actually expressed their gratitude for the podcast's existence because they practice isolated. So they don't have a large group that they're with. And through the podcast, they actually listen and use it as sort of a discussion tool, and they build community through it. And, that's kind of like the end goal. When Luke and I started doing this, we were, recording in our closets with blankets over our heads, trying to figure out how to deal with the acoustics. And I was like positive the only people listening was Luke, myself, and my dad. I was like, we've got 3 listeners, Luke, but at least we're learning something. But I'm really very appreciative of how the podcast has grown, that people listen, and that it helps them to kind of keep up with the dermatologic literature.
The University of Utah is very forward thinking about this stuff as well. They certainly appreciate that we're doing this work.
That's awesome. Well, over the last 25 years, I think it's safe to say most of the interesting things that have been happening in the world of dermatology have been related to psoriasis.
Mm-hmm.
And it doesn't seem to be slowing down. It seems to be accelerating over time. You must have covered some really interesting things about psoriasis. Tell me about it.
So we try to make an effort to discuss the trials that get new drugs approved. And so we've talked about a lot of our new fancy psoriasis medications. We're not sponsored by any of them, but I'll say based on the data that I've reviewed, they're all pretty great. My current favorite is bimekizumab.
Mm-hmm.
It seems to have higher efficacy than the others in the same space. And oh, you've got your own pimping bell. Oh my goodness.
Oh my God, that's amazing. I love that.
So, listeners, on Dermasphere, we have what we call the pimping bell. Remember that pimping means to ask questions of your learners, and it sounds like this. Did not realize that Dr. Feldman had one as well. And then, importantly, bimekizumab doesn't seem to be any more expensive than the other ones. We've discussed in the podcast this potential association of IL-17 inhibitors, so bimekizumab's an IL-17, with an association with inflammatory bowel disease. Something else we covered, there was a picture of a diseased colon that was resected from somebody in that article. Not something we usually see in the dermatology literature.
Did that one get grossest image? Was that grossest image winner for the dermies?
Yes, I think we gave that one out. We give out awards at the end of every year. So grossest image was this diseased colon. So as long as you screen your patients, make sure there's no personal or family history or concerning symptoms of inflammatory bowel disease, that tends to be the one I use. And I'm not sure I would do that if it wasn't for me just looking this up on the podcast. I would have had to have run into the data some other way.
Some of the interesting things we've looked at also is some of the more, you might consider it fringe literature, but we've actually covered psoriasis as a disease state in over 20 episodes on the Dermasphere podcast. I think we've reviewed over 22 articles discussing psoriasis as a disease state. One of the most interesting ones was actually looking at the exposure to the Western diet and the potential inducement of psoriasiform dermatitis through causing inflammation on the IL-17 axis. And the figure from that, I think, also won like coolest image, I think. And it was like an image of a mouse with like Have you ever seen Aqua Teen Hunger Force? It's like a very silly cartoon on Cartoon Network where there's a French fry and there's a meatball and there's like a shake that are all characters Master Shake. And it had sort of a cartoony image of that kind of food and the mouse and then like the gut and then psoriasis. And they actually did find that the Western diet, when fed to mice, increased inflammation in the IL-17 axis and was able to induce skin inflammation analogous to psoriasis. There was another really interesting article we looked at about dietary supplements and potentially therapeutically using those to mitigate psoriasis. And so the gut skin axis is something that's very interesting in the field. And I think that we actually see that a lot with many of the therapeutics sharing therapeutic efficacy across inflammatory bowel disease and psoriasis. And then there's this question of IBD activation through IL-17 inhibition. And, it really highlights the fact that the immune system is very delicate in its balance, and there's a lot of feedback loops. And understanding those can help us to pick the right therapies for patients, just like Luke was saying, proper patient screening. There are certainly things that you want to think about whenever you're visiting with a patient who has psoriasis for the first time to try to pick a therapeutic for them, or if you're choosing a new therapeutic because they've had treatment failure or side effect, really delving into their family history, their personal history, their lifestyle, and trying to find the best fit. We are in a wonderful period as dermatologists and doctors who treat psoriasis, in that we have a wealth of options now. We used to have phototherapy only. We had, as a dermatologist named Tarbox, I have to bring up Geckerman. Like the fact that we would bring people into a hospital, put tar on them, then put them in a light box, Tarbox makes it work. There are these options now that are much more convenient for patients, much more accessible for patients, and can actually be tailored to the individual person, their medical history, and their lifestyle. That's a really wonderful space to be in. What are your kind of practice pearls for psoriasis, Dr. Feldman?
When I'm thinking about trying to organize the structure of presenting information on psoriasis, I think starting with like disease state and quality of life stuff first, and maybe, comorbidities management, and then topicals, then systemics. And you brought up the disease state. Yeah, it's cool that we know this axis, this IL-23, TYK2, IL-17 axis. Before I got to Wake Forest, the psoriasis specialist here was this fabulous psoriasis specialist, Michael Zanoli. He and Joe Urizzo started a Geckerman Center here at Wake Forest. And Wake Forest also has this big primate colony where they do cardiovascular research.
Wow.
And one of the monkeys in the high-stress Western diet arm of their study developed psoriasis. This is a primate model of psoriasis that they had.
Wow.
I don't think you've covered this article because they probably wrote it before you were born. But, it was limited psoriasis in Urizzo. I think thought, well, we got to make this worse. We got to, and so he thought, well, I'll just give him some steroids, withdraw the steroids and cause a flare. And they cured the one animal model that was ever, one primate model of psoriasis.
Oh my gosh.
Yeah, the psoriasis one. But they also took that animal out of the high stress environment from the colony that was in because of the rash. And
Yeah.
who knows, maybe that had something to do with it. It makes me wonder if, in addition to staying on top of all the up-to-date stuff, covering, one of the really old classic articles every now and then might be a cool thing to do to remind people about stuff.
I like this idea, like a flashback.
We've talked about a few oldies. We talked about one from West Berlin. Remember that? So that was like back in the 70s. We've talked about a couple articles that talked about, can you address psoriasis to some degree by addressing diet and supplements and stuff? And some of the authors make a fairly decent case that at least in some patients, something like that could be helpful, but requires like some significant lifestyle changes and diligent adherence. It made me start to think about a theme that's come up throughout the podcast, which is that some of our diseases like psoriasis and atopic dermatitis that we call just one name, it's probably some kind of final common pathway. It seems like there's different ways to get to the IL-17, IL-23 tick stuff. And perhaps in different patients, addressing it in different upstream measures could be more or less effective.
Yeah, I think that's right. So for the bulk of people who have psoriasis have relatively limited disease. I'm not saying patients, but the bulk of humans in the population that have limited disease just need topicals. Have you covered interesting developments in the world of topical treatment of psoriasis?
Oh yeah, absolutely. This is an era that has some topicals that rival the efficacy of some of our earliest biologics. Actually, I've been very impressed with the development of roflumilast, which is Zoryve, and tapinarof, which is Vtama. I also like that. I don't. Every time I hear the name tapinarof, I think of like a Russian prince for some reason because it just sounds like that. But the efficacy of these topicals, especially in focused or limited psoriasis, can be quite astonishing. And if I've had some patients that are just not ready for a systemic agent from their own personal perspective. They don't want to take a medication by mouth or an injection, but they have some pretty significant plaque psoriasis and have really been impressed with the efficaciousness of these newer therapeutics. Specifically, Zoryve and Vtama have had pretty impressive showing. Now, access is something that you have to navigate because they are newer therapeutics. And both of the companies that make those topicals do have pretty robust patient support programs. So we've been able to get a lot of patients on those medications. Patients tend to tolerate them well. I do notice that there is a greater concern from patients in general about using topical corticosteroids, which are still a workhorse of our practice. Are you encountering this, Dr. Feldman, where patients kind of come in ready to say no to anything that's a topical steroid?
No, but that's perhaps because I never use the word steroid in front of a patient. You know,
Anti-inflammatory,
Hmm.
cortisone type medicine.
You got to meet people where they are.
yeah. When I prescribe a lot of topical steroids, and I would have thought that if you gave them clobetasol and it didn't work, it was probably because they didn't use it, and therefore, if you give them a different topical, they wouldn't use that either.
Yeah.
I think you're seeing a lot of success. You must be doing a great job getting people to put that stuff on. So there's been some topical development. How about in the systemics?
Well, we mentioned bimekizumab, and there have been other biologics as well, including some JAK inhibitors that are now approved for psoriasis, like deucravacitinib. Thank you. And then there are more in the pipeline. So I'm sure you guys have discussed what you guys are excited about. I honestly don't pay that much attention to the in the pipeline stuff because some of it never gets out of the pipeline and then I've wasted my time perhaps or at least used it inefficiently trying to learn about these things. But I've heard some buzz about an oral IL-17 inhibitor and I think that's intriguing because there are some people who really don't want shots and the IL-17 inhibitors work really well.
Yeah. Have you heard about the oral IL-23?
No.
Ooh, oh, something new to cover. Yeah, the one thing about the oral IL-17 that makes me a little nervous is because, okay, IL-17s can maybe increase your risk of yeast infection. I mean, if you're born without IL-17, you get chronic mucocutaneous candidiasis. But that inflammatory bowel disease risk, and here you'd be given it orally, so it'd be going right to the bowel.
Yeah.
Would there be more inflammatory bowel disease risk? And you know what? The immune system's inscrutable. I have no idea whether there will be or not. We'll have to see. But an oral IL-23,
Hmm.
especially if they have a component of inflammatory bowel disease along with their psoriasis, because all that psoriasis, psoriatic arthritis, inflammatory bowel disease, all the genes from that IL-23, TYK2, IL-17 axis are all related.
And some of the articles we covered are about ways to use the medicine that are a little different from paradigm. So one article we looked at talked about treating guttate psoriasis. And so I think we've all treated patients who were children that had an upper respiratory infection and they come in with guttate psoriasis acutely. And we have a good feeling that this is going to be a time limited event for this patient. When they develop it as an adult, you get a little bit more nervous. The article discussed treating guttate psoriasis with systemic medications, specifically IL-23s or IL-20 or IL-17s, because of the fact that you may have a window of opportunity to prevent chronicity and disease from a patient who has that presentation that's kind of outside of that typical childhood presentation after an upper respiratory infection. And they talk about some of the memory pathways that get implicated in established psoriasis vulgaris, like the Langerhans cells and the tissue resident memory cells that can sort of sustain disease memory and are the reason why the condition can keep recurring in the same place. We're talking a lot about these tissue resident memory cells as well in conditions like alopecia areata. And they're really one of the reasons that a condition kind of keeps homing to the same place. I wonder actually if we wouldn't find the same population of cells in things like fixed drug eruption, where patients get the eruption in the same place every time on representation of the drug.
What a great thought.
I think making these connections across these disease states as we start to understand the way the immune system talks to itself is going to be the forefront. And I think one of the best uses of AI technology as we move into this brave new world is going to be like realistic 3D modeling of an intercellular like environment. Because when we look at these pathways, we're used to them being presented in 2D, where we have our transmembrane receptor and then our downstream signaling. But the fact of the matter is none of these things are happening in isolation, right? These messengers and these cytokines and these conformational changes are all happening packed up against other cytokines and conformational changes in proteins. How do those things affect each other in a real cell environment? So my hope is that alongside using AI to make witty, memes and cute mock-ups of what you would look like as a Barbie, we could potentially use it as well to model the intercellular environment and really understand inside the cell how these different pathways affect each other. Because it's not possible that they don't.
Before I let you go, is there anything you would tell your listeners about how you expect Dermasphere to evolve?
Ooh, so we are trying to build some resources for our listeners. A lot of our listeners are people in training or people who are aspiring to train in dermatology. And so we're working on building resources about how to start doing research, how to write your first case report, how to conduct a systematic review, how to do a meta-analysis. There's resources out there, of course, that live on the web free, but I think that having them in a place where people can find them easily and maybe having them tailored a little bit more specifically to the world of dermatology, as well as some advice for people trying to pursue dermatology residency, because I've realized as I've gone and done talks at different institutions as well as at different meetings that there's an unmet need for students that don't have a home derm program to have some mentorship in how to navigate the dermatology match. And so I have a little kind of project that I call the No Drama Derm Mama. And the point of it is to like help people who don't have access to a local mentor navigate the somewhat challenging and ever more difficult process of attacking the dermatology match, because it is a very competitive specialty. And, every year we have great candidates that go unmatched, and trying to find ways to help improve the odds of these good people finding a spot in our specialty, I think is an important thing. And then Luke, any other things?
I often think to myself, should Dermasphere try to evolve into a larger platform space? Like, should we have educational videos? Should we have things that target residents specifically? Should we have more stuff at the general population? And then I think, yeah, maybe that sounds kind of cool. And then I fall back into the stuff that I always do. There's just like, you need time and other resources. So that stuff I think about sometimes. Maybe it'll happen. That'd be fun.
Awesome. Today we've had Doctors Luke Johnson and Michelle Tarbox talking about the future of psoriasis treatment. Okay, a couple key takeaways of this episode is the advances we've had in topical therapy for psoriasis, the advances we've had in systemic treatments, but most importantly, the advances we've had in how to learn about dermatology. Dermasphere is this awesome podcast. I'd strongly encourage you to take a look. Thank you all so much for joining us. This is Dr. Steve Feldman for In Discussion.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen R. Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on psoriasis.